In this film, the steps for examining a pregnant woman will be demonstrated. In this film, the demonstration will be shown and alternate between two pregnant women. The obstetric abdominal physical examination of the pregnant woman is especially important since both the condition of the mother and the baby will be assessed. In preparation for the examination, the healthcare professional should ensure that the fingernails are short, neat, without nail polish. Artificial nails should not be worn. There should be no jewellery on the hands or wrists. And hands should be cleaned with soap and water or sterilised with alcohol. The pregnant woman should be given the opportunity to empty her bladder before the examination. For the examination, the pregnant woman is placed in a supine position, with her head supported by a pillow and her arms alongside her body. To prevent maternal cardiovascular compromise and fetal stress, the woman may be placed in left lateral tilt by raising her left side by 15 degrees using a pillow. The steps of the obstetric abdominal physical examination are explained to the patient. The obstetric abdominal examination begins by looking at the patient. The general appearance of the patient should be noted. Whether she appears stable, comfortable, pale, or breathless. Close attention is paid to the face for signs of anemia, jaundice, nasal congestion, and facial edema. The legs and feet of the patient are examined for edema and varicose veins. After the general assessment, the abdomen is examined. The pregnant woman is instructed to expose her abdomen. Firstly, the shape of the abdomen is observed. Note that the shape of the abdomen in a normal single pregnancy is usually symmetrical, unless there is a polyhydramnios or multiple pregnancies. After observing the shape of the abdomen, it is inspected for surgical scars. This may give an idea of the patient's surgical history and may be important in the management. Note that for the observation of a scar from a caesarean section, the pants must be lowered further down than seen here. Next, distended superficial veins are observed, as well as umbilical hernias, which can be seen by asking the patient to cough, as well as cutaneous signs of pregnancy, which include the linea nigra, a dark line from the umbilicus to the pubic region, the striae gravidarum, which are purple striae of no clinical significance, the striae albicans, which are white striae giving an indication on parity, and lastly, fetal movements can be seen, giving an indication of viability. After the abdomen is inspected, the abdomen is palpated. Take note that the hands of the healthcare professional should be warm and the uterus should be non-contracted. If on palpation the uterus feels hard and contracted, the woman is asked to take a few breaths to relax, thereby relaxing the uterus. A non-contracted uterus is important for a reliable outcome. The first maneuver, also known as the fundal grip, is used to assess the growth of the uterus by measuring the fundal height. The uterus will become an abdominal organ at 12 weeks of gestation. As the gestational age progresses, the uterus will grow. The fundal height will reach the umbilicus at approximately 20 weeks of gestation, and it will reach its maximum height at the level of the xiphosternum at 36 weeks of gestation. After 36 weeks, the fundal height will decrease since the fetus will descend into the pelvis. To assess the growth of the uterus, the symphysis pubis, umbilicus, and the xyphosternum process are used as anatomical reference points. Therefore, before performing Leopold I, the position of the umbilicus needs to be determined. This is done by placing the little finger of the left hand on the xyphosternum and the little finger of the right hand on the symphysis pubis. Next, the thumbs of both hands are crossed to determine whether the umbilicus is positioned centrally, since the uterine growth is described in relation to the umbilicus, as seen here. To determine the fundal height, the ulnar edge of the left hand is used to press down in a stepwise manner, starting at the xyphosternum, downwards to find the fundus. This will be felt as the first bit of resistance to the ulnar side of the hand. If the fundus is not found upon palpation, percussion might be used. Once the fundal height is determined, it should be measured from this point down to the pubic symphysis, which is found by palpating a few centimeters above the pubic hairline. In this specific example, the measurement is 34 centimeters. After measuring the uterine growth, the fetal part lying at the fundus will be examined. This is done by placing two hands on the part presented at the fundus and gently pressing down to feel. The fetal head is round, hard, and moves independently of the body, whereas the fetal buttocks are rounder, softer, and symmetrical, and unlike the head, move with the trunk of the fetus. Take note once more of the different maneuvers to determine the fundal height. The fundal growth, and the examination of the fetal part in the fundus. With the second maneuver, also known as the umbilical grip, the position of the baby and the amount of amniotic fluid is determined. While still facing the woman, the healthcare provider continues to palpate the abdomen with deep pressure using the palm of the hands as seen here to determine the location of the fetal back. The right hand remains steady on one side of the abdomen while the left hand explores the right side of the uterus. This is then repeated on the contralateral side, using the left hand to steady the uterus and the right hand to explore the left side of the uterus. The back of the fetus will feel firm and smooth, while the fetal parts, such as arms and legs, would feel like small irregularities and protrusions. Take note that in this video, the fetus is in a longitudinal cephalic position with the back at the maternal right side. Other positions are a transverse lie position, where the fetus is positioned sideways, as seen here. A breech position, where the fetal head is positioned in the fundus of the uterus, as seen here. On palpation, the number of pregnancies can also be determined, as well as the estimation of amniotic fluid. In general, if there is an excessive amount of amniotic fluid, the uterus will feel tense and it will be difficult to feel fetal parts. If there is a shortage of amniotic fluid, the uterus will be soft and the fetus is very easily palpable. With the third maneuver, also known as the Paulick's grip, the healthcare professional may determine what part of the fetus is lying above the pelvic inlet. This maneuver validates the findings of the second maneuver. With the thumb and index finger of the dominant hand, the fetal part lying above the pelvic inlet is firmly grasped and moved from side to side. The head is firm compared to the breech, and in contrary to the breech can be balloted. Take note that it is important to warn the patient of discomfort and pain. The fourth maneuver, also known as the pelvic grip, is used to determine the level of engagement. The woman is asked to bend her legs, since this may relax the abdominal muscles and thus make palpation of the fetal head easier. Additionally, the woman is asked to inhale deeply and exhale slowly during the palpation. To perform the fourth maneuver, the left hand of the healthcare professional is placed on the left side of the uterus, and the right hand is placed on the right side of the uterus, approximately 2 centimeters above the inguinal ligaments. Then, both hands are pressed downwards and inwards in the direction of the birth canal. If the presenting part moves upwards on examination, this gives the indication that the presenting part is not engaged. If the presenting part is not moving on examination, the presenting part is engaged in the pelvis. Take note once more of the bending of the legs of the pregnant woman, the placement of the left and right hand above the inguinal ligament, the breathing technique to relax the muscles, and the palpation of the fetal head. After palpating the uterus, auscultation is performed to assess the fetal heart. A handheld Doppler in combination with ultrasound gel may be used from 12 weeks onwards, as seen here. Take note that the Doppler is positioned at shoulder height on the side of the fetal back. After 28 weeks of gestation, a Pinard stethoscope may be used to auscultate the fetal heart. The Pinard stethoscope is placed in line with the fetal shoulder on the maternal side where the fetus shoulder is positioned. Take note that the stethoscope should be held in place by holding it against the maternal abdomen and your ear. The stethoscope should not be held to avoid hearing your own pulse sounds, which could be transmitted through the device. The fetal heart should beat regularly at 110 to 160 beats per minute. The maternal radial pulse may simultaneously be palpated, so a distinction between the maternal heartbeat and fetal heartbeat can be made. However, this is not shown in this assessment. After the fetal heart is assessed, the ultrasound gel is taken off the abdomen and the woman is asked to cover her abdomen again. If necessary, the healthcare professional may help the woman to her feet. After finishing the obstetric abdominal examination, the findings and management are documented and discussed with the pregnant woman.